Thank you, ma'am. It is always an honor to speak in our parent institute and in front of teachers. I still have a student in me who feel stress, palpitations when we present cases in PG meetings. So if I make some mistakes or fumble somewhere, so forgive me for that. Dr. Chan, ma'am, and Dr. Khandai, sir, all are my teachers. So please. So today I am going to speak on special situations and needs special attention. I will be mainly focusing on gestational diabetes, which is very important topic in our practice, particularly as an endocrinologist. I feel maximum patients, DM patients, and it is very difficult, tricky situation to handle these patients, and you need special attention to keep their sugars under control. So, to begin with, I have a case for you students particularly. This is a 25-year primary gravidia. She is 24 week of gestation. Tolerance test was done with 75 gram of glucose. Her fasting is 98. 1 hour sugar is 178 and 2 hours is 160. So what is your opinion? Is she a GDM patient or these are normal values? Anyone from students? Any answer, yes or no? Okay, so similar condition faced when I was in my PG days. I just entered in the second year of the PG. I was sitting in diabetic OPD and with my lecturer, Dr. Hardas ma'am. And similar case was referred from the gynecology department. And I said, ma'am, the sugars look very pretty normal. Why they have referred us? But this is not the condition. Because these are not normal values for the pregnant woman. So these are, we'll cover this later. So at the end of my talk, I would like that you should about what is gestational diabetes, the definition of gestational diabetes, impact on mother and fetus, what is the diagnostic criteria and when to test for this blood sugar level, how to treat these patients, how to monitor them, what is the role of oral hypoglycemic agents, and briefly about the prenatal counseling for pre-existing diabetic patients who are planning to be pregnant. So definition wise, any degree of glucose intolerance with onset or first recognition during pregnancy. So any glucose abnormality above normal, it is considered as a gestational diabetes. It may detected in the first or second or third trimester, but the first time detection of glucose abnormality is considered as a gestational diabetes. It has huge impact, particularly on the fetal outcome as well as maternal, and that's why this is very important from treating diabetologists from point as well as the obstetrician perspective. So when you consider off screen, there are many complications which are associated if the sugars are not under control, particularly if the sugars are elevated in the first trimester, first 3 months, then that child may have congenital abnormality in the form of cardiac abnormalities, transposition of great vessels, they may have VSDs, there may be CNS or skeleton malformations, many more. So first 3 months are very important because organs are developed in that period, and if the sugars are elevated, many times this patient or the child may develop congenital malformation. Also, the risk of abortion increases significantly. And if the sugars are elevated in second or third trimester, then the child may be macrosomic, large for gestational age, and there is an increased fat mass. And also, when the child born, there may be the neonatal complications in the form of prematurity, perinatal asphyxia, respiratory distress, metabolic complication in the form of hypoglycemias, hypocalcemia, polycythemia, hyperviscosity, low iron store, hyperbilirubinemia, and cardiomyopathy. So remember, if the sugars of mother are high during the delivery period, the child may develop hypoglycemia after delivery because he exposed to excess blood glucose level, and that's why his pancreatic system gets stimulated and there is an increased insulin secretion, and that's why in postnatal period the child may land into the hyperglycemia. And in long term, that child may at risk for the development of the obesity, type 2 diabetes, or PCOD problem. And obviously for mother, there is an increased risk of preeclampsia, increased risk of premature delivery, abortions, postpartum hemorrhage because the child is large for gestational age, and there is a polyhydramnios, the risk of postpartum hemorrhage is also high, requirement of the caesarean section is also required. So these are some risk factors for gestational diabetes. If the lady is obese with the BMI of more than 30 kg per meter square, if the patient has previous history of macrosomic baby weighing around 4.5 kg or more, previous history of gestational diabetes, family history of diabetes, first degree relative with the diabetes, certain ethnic group, particularly the Asian or African ethnic, if the age is more than 25 years, if the patient has pregnancy-related hypertension, if there is an unexplained stillbirth or miscarriage in previous pregnancy, and the polycystic ovarian syndrome, these are the patients who are at risk for development of the gestational diabetes. If you look at the guidelines, in first trimester, you should check blood sugar only those patients having these risk factors. But since the prevalence is very high in our country, we check for each and every patient, even in first trimester as well as in second and third trimester. So these are the diagnostic criteria for below 13 weeks. If the fasting blood sugar is more than 126 and the random plasma glucose more than 200 and the HbA1c is more than 6.5, that is considered the over diabetes. That is standard diabetic diagnostic criteria. Fasting more than 126, post meal more than 200, HbA1c of more than 6.5. So that is considered old diabetes. That patient has diabetes, but she was not aware about that. And the gestational diabetes is considered if the fasting is between 90 to 125. So fasting is below 126 is considered as the gestational diabetes in first trimester. And these are the criteria when you check the blood sugar between 24 to 28 weeks. This is also important. Why 24 and 28 weeks? Because the hormonal secretion are maximum on that period, and maximum dysglycemia occur during this period. So you have to check for the gestational diabetes between 24 to 28 weeks. You have to do the oral glucose tolerance test with the 75 grams glucose. There are many guidelines with different values, but remember just this one. The 75 gram of glucose OGTT has to be done. The fasting is more than 92, 1 hour is more than 180, and 2 hours more than 153 is considered abnormal. So any one value, no need of two values. Even if the fasting is elevated, that patient is gestational diabetes. Even 1 hour value is elevated, then the patient is gestational diabetes. So these are the diagnostic criteria you have to remember. This is from Endocrine Society Guidelines, which was published in 2013. These are freely available online. You can go through the guidelines. This is Endocrine Society Guidelines for the gestational diabetes. And this is American Diabetic Association Guidelines 2021. And they have given two methods. One is one-step strategy and another is a two-step strategy. What one-step strategy is nearly similar to what the Endocrine Society has described. The fasting more than 92, 1 hour of 180 and 2 hours of 143. While in two-step strategy, they do random 50-gram glucose challenge test, and if the sugars are more than 130, 135 or 140, they post that patient for the 100-gram oral glucose tolerance test, and these are the values. Fasting more than 95, 1 hour more than 180, 2 hours more than 155 and 3 hours 140. So any two are needed to consider as a gestational. But you don't keep the confusion. You can remember just one guidelines. One is Endocrine Society and this is ADA. And the values are fasting more than 92, 1 hour more than 180 and 2 hours is more than 153. So coming back to our case, her sugar fasting was 98. That means it was elevated. It is more than 92. 1 hour is 178. That is okay. And 2 hours is also elevated. So this patient is case of gestational diabetes. So, So now this is gestational diabetes and that patient will need treatment further. Now another case for you. This is a woman, 34 years. She is G2P1, 28 week of gestation. And since she had a family history of diabetes, they also just by herself, she did fasting blood sugar, and which was found to be 101 milligram per deciliter. So does she need GTT? As I have already mentioned, GTT is done for the diagnosis. So will this patient need GTT for the diagnosis? Anyone from students? Yes or no? Again the same. Yes or no? No. Yes. Because I have already mentioned even single value is considered as a gestational already. Already she has elevated fasting plasma glucose more than 92. So that means that patient is gestational diabetes. Remember, 75 gram glucose is just a screening test to find out whether that patient is having gestational diabetes or not. This is not for the monitoring or for the treatment. So if even a single value is positive, there is no need to repeat the GTT. That patient is gestational diabetes and you have to treat her as a gestational diabetes. So now our first case is detected to have gestational diabetes, and now next question comes, will you start that patient her treatment? And if yes, then what? Again for a question for students. Anyone? So will you start her on metformin, you will start her on insulin or any other drug? So yes, she is gestational diabetes and you have to start her on the treatment. And treatment are mainly three. One is non-pharmacological treatment and the pharmacological. Remember, this non-pharmacological treatment is also very important in the gestational diabetes because they just have mild elevation of the blood sugar level. Many patients get controlled with proper diet and exercise as well. And if the sugars are not getting controlled, then you can advise them the pharmacological treatment in the form of insulin, oral agent, either metformin or the glibenclamide. These are recommendations from American Diabetic Association again, and they said the lifestyle behavior changes is an essential component of management of gestational diabetes mellitus and may suffice for the treatment of many women. Insulin should be added if needed to achieve the glycemic target, and insulin is the preferred treatment for treating hyperglycemia in gestational diabetes mellitus. Metformin and glyburide should not be used as a first-line agent as both crosses placenta to the fetus. Remember this line, insulin is the first drug of choice, and metformin is only prescribed if the sugars are not getting control with the proper insulin doses or there is a fluctuation. And other oral or non-insulin injectable glucose lowering medication like long-term safety data. Diet, simple diet plan, don't go for a fancy one. Patient is eating, you have to modify that only. So history of past and present meal is important. Multiple small meals are always advised, and retain the native dietary pattern. Just reduce the carbohydrate content, you can increase the protein content of that patient, and always avoid powders. Many times gestational the pregnant ladies are prescribed for the protein powders, so you should avoid those protein powders or health food because they also increases the blood sugar levels. The objective of medical nutrition therapy is to determine the energy need, set appropriate weight goal, develop an individualized and nutritionally balanced plan, provide education concerning nutrition related lifestyle issue, counsel on the importance of normal glycemia before, this is also very important, you have to counsel them before the pregnancy, during and after pregnancy, and evaluate adherence to the meal plan. Exercise, yes, they can do the exercise. Simple walking is considered as one of the best exercise. Daily 15 to 20 minutes or half hour of walking, mild light cycling, or about 5 to 10 minutes of walk after each meal is also sufficient. And many times they do get control with these lifestyle measures. Self-monitoring, monitoring is very important because until unless you do not have the reading of blood sugar, you will not say that the patient is under control. So monitoring is required, and in monitoring you should do the fasting and the 1 hour postprandial. Remember, this is 1 hour value. Many times in our practice we check for the 1.5 hour or 2 hours value, but the 1 hour postprandial is very important in pregnant lady because in study it was found that 1 hour has significant association with the complication or like macrosemia, neonatal hypoglycemia, and cesarean delivery. So 1 hour are recommended for pregnant lady. And preprandial sometime, and 3 AM value if you suspect there is a nighttime hypoglycemia. But mainly you have to check for the fasting and 1 hour postprandial value. And target I have already mentioned that fasting, the targets are fasting should be below 90, and the postprandial value, if you consider the 2 hour value, it should be below 120, and 1 hour value should be below 140. So these are the targets for the gestational. These are different from the normal diabetic patient. Remember, in pregnancy you have to be more stringent, and the fasting should be below 90, 1 hour should be below 140, and 2 hours value should be below 120. When to start drug? When you give a fair trial, generally we can't wait much in the pregnancy, 1 week or 2 week trial of lifestyle modification. And if sugars are under control within target range, yes, you can continue with the lifestyle. But if they are not under control, then you have to start the patient on the drugs. And glycemic pattern guide the treatment. Like if only there is an increase in the postprandial level, you can start on the short acting analogs. If the fasting hyperglycemia, then you can start on the basal long acting insulin. And if the sugars, both fasting as well as the postprandial hyperglycemia is there, then you have to start them on the basal bolus insulin regimen, or you can use premix as well. But the basal bolus insulin regimen are preferred in pregnancy for better control. And glucometer training is always needed for these patients because they have to check sugars very frequently. Then question comes, which insulin and which regimens? Various regimens are available. Prandial means where you give only short acting before each meal. Basal insulin, longer acting insulin at night time, or basal bolus and the premix. But always this basal bolus is preferred in the pregnancy. Again, that will depend on the which type of hyperglycemia is there. and analogs are preferred over the human insulin because they are very short acting, quick acting, so there are flexibility in giving the treatment. So rapid acting analogs are preferred over the human insulin. Rapid acting like Noah Rapid, which is from Novo company, or Lispro, it is our one. They more accurately target the postprandial blood glucose level. There is more flexibility in meal time because they are very quick to start. So just before meal, patient can take and they can start on the meal. Lesser hypoglycemic episode, particularly the intermeal hypoglycemia, is prevented with the rapid acting analog, and the risk of macrosemia is also reduced. No greater risk for the worsening of the retinopathy, and majority of the guidelines now recommend that the analogs should be preferred in the pregnancy over the human insulin, and more useful when started before conception because you can decide the dose to be given in pregnancy. Basal analog, only one basal analog which is recommended is Ditamir. Other like Lantus insulin, Glargine insulin, or degludec insulin still not approved to be used in the pregnancy, but the again guidelines says if the patient is taking them pre-conception, may continue to use them. So if first time patient is detected during pregnancy, it is better to start on the Ditamir, or you can use intermediate acting Insulatard as well, but Lantus and degludec should not be used. But if the patient is already on the Lantus prior to the pregnancy, then you can continue it. And there was no unexpected or adverse maternal or fetal outcome was. Medical management, again same, insulin and multiple dose is preferred. Patient sometimes may require hospitalization if the sugars are very high, particularly in the first trimester, for rapid control. Education and self-monitoring is must. And initiation and monitoring of insulin therapy is same as the standard care, but the glycemic target are more stringent. You have to keep the sugars very tight. This is just in brief about the metformin because it is rampantly used in gestational diabetes patient. So what the guideline says about the use of metformin in gestational diabetes. This is from Endocrine Society guidelines, which was published in 2013, and they said you should use metformin only if there is no satisfactory control with medical nutrition therapy plus exercise, and those who refuse or cannot use insulin or glyburide and are not in the first trimester. So remember these lines these are not my words, these are from the guidelines, Endocrine Society guidelines. So they should not be the first drug of choice. Insulin always the first drug of choice. And if the sugars are not getting control, or if the patient is not willing, then only you can use metformin, and the patient should not be in the first trimester. As this is because metformin freely crosses the placenta, and there found to be that increased rate of preterm low birth weight when the patient is started on the metformin. These are two RCTs, randomized controlled trial, are there for the metformin use in the diabetes. The one is MIG trial, this is large trial, and another one was from the Moore. In MIG trial, MIG is metformin in gestational diabetes trial. Nearly 750 gestational diabetes patients were randomized to receive metformin and insulin, and they found that there is no significant difference between the fetal outcome. But when this cohort were followed over years, and in future, the patient who were treated with the metformin, they have they are obese, and there are more chances of metabolic complication when metformin used as compared to the insulin. Similarly, in this study also, similar results were found when they followed over a long period. And this is one recent meta-analysis was published, and they concluded that metformin exposure resulted in smaller neonate. So at birth they will be small, but with acceleration of postnatal growth resulting in the higher BMI in the childhood. So as such, there is no congenital malformation, but this risk of metabolic complications increases significantly when the metformin is used in gestational diabetic patient. Postpartum follow-up is also very important. Once the delivery happens, many times the patient get normal glycemia, but you have to follow up because these are the patient at risk of developing diabetes in the future. So schedule a visit after 4 to 6 weeks, perform GTT, and if the GTT is normal, then you can follow up them annually with HbA1c and the fasting plasma glucose. If the values are impaired, then again you have to monitor, you have to advise them lifestyle modification, and 3 to 6 and the fasting plasma glucose, and then accordingly you have to decide. And if the patient is found to be diabetic, then you have to treat appropriately. So this is the end for gestational diabetes. If you have any question about the gestational diabetes, I will be happy to answer. The next is for Ramadan. Yeah. Yeah. Yes. So always the first drug or the first treatment is the lifestyle modification, because as I said, many patients do get normal sugar with this lifestyle modification, and we generally do not wait for much time. It's just 1 week of medical nutritional therapy, and if the sugars get controlled, then it's okay, you can continue with that, but if not, then you have to start on the insulin. Remember, in GTT, we do test with the glucose, and no one eats that much glucose daily. Okay. So many times, this is, as I said, the GTT is a screening test, and that's why we don't follow after once the patient is positive for gestational diabetes, we just follow the fasting and the post-meal plasma glucose. So many times this patient get normalized with the medical nutrition therapy, but you have to be vigilant. You have to ask them patient to come after 1 week and check for the fasting and post-meal. And if they are not getting control, then yes, obviously you have to start on the insulin. Anyone? So I will be very brief because this already taking too much time. So this is another interesting topic, that is Ramadan fasting and diabetes. This is again a tricky situation because the patient fasts for nearly more than 12 hours during this period, and it is very tricky situation how to treat this patient, which medicine to be give, and how to monitor this sugar. So nearly 40 to 50 million Muslim patients with type 2 diabetes observe fasting during the holy month of the Ramadan. They, on an average, they fast 12 hours a day during Ramadan. And although Islamic rule exempt patient with illness from fasting, almost 79% of patients with type 2 diabetes prefer to fast. And this is a fact remain. Many times even the patient with high doses of insulin, still they want to fast, and you are very in tricky situation. These are the risks associated with the prolonged fasting in the Ramadan period. The patient may land up into the hyperglycemia, particularly if the patient is in good control. They may have hyperglycemia, diabetes ketoacidosis, because many times patients skip their medicine or insulin because of the fasting state, and again because there may be the dehydration and the thrombosis risk as well. These are two situations. If the patient is well controlled on the diabetes, they are at risk of developing hyperglycemia because of the fasting, and you have to reduce the doses or adjust the doses of the medicine as well as the insulin if the patient is in good glycemic control. On the contrary, if the patient has uncontrolled blood glucose sugars, the patient may lead to the HONGs or the decay because of the increased hepatic gluconeogenesis, poor adherence to the treatment, and worsening of the hyperglycemia. So these all conditions can occur during Ramadan period, and you have to be very vigilant. These patients should not fast again. With gestational diabetes, patient elderly with comorbid conditions, with type 1 diabetes requiring insulin, patient with autoimmune dysfunction, hypoglycemia awareness because they may not aware about the hypoglycemia and they may land into the emergency. Patient with uncontrolled type 2 diabetes or brittle diabetes who need insulin 2 to 3 times. This patient should be advised that they should not fast. These are the guidelines, and this is from International Diabetic Federation, and this says before Ramadan start, you should quantify the risk. You advise very high risk patient to not fast. You advise them for the frequent blood glucose monitoring. You should advise for the fluid and the dietary habits on exercise as well as the medication adjustment. Educational counseling is very important. You should tell them the importance of glucose monitoring, when to stop the fast, how to plan the meal, and appropriate meal choices to avoid the postprandial hypoglycemias as well as the hyperglycemias. Breaking the fast, this is very important. These patients should stop doing fast if they develop the hypoglycemia, blood glucose below 60, occur at any time during the fast, or if the blood glucose exceeds 300, and if the blood glucose drops to less than 70 mg per dl in early hours of the fast, particularly if the patient is on sulfonylureas like glimepiride or gliclazide or insulin, then they should stop doing the fast. And fasting should be avoided in 6 days as well. Meal planning, use more slow release food. This is again important because they have to fast for more than 12 hours. So in early morning hours, they should use food which are slow energy release that will prevent the hyperglycemia as well as the hypoglycemia. They can use wheat, semolinas, beans. Minimize food with a high saturated fat like ghee, samosa, which is commonly eaten, pakoras or pakodas. Use small amount of olive oil or rapeseed oils for cooking and encourage adequate fiber intake. Regular mild exercises can be done. These are recommendations for use of various oral hypoglycemic agents. There is not much to worry if the patient is on drug which do not cause hypoglycemia. There are many drugs now like metformin, pioglitazone, SGLT2 inhibitors, DPP4 inhibitors, GLP1 analogs, acarbose. They do not cause any hypoglycemia. There are only 2-3 medicines which causes hypoglycemia like sulfonylureas, glimepiride, gliclazide, insulin and glenide. These are only 3 category of drug which causes hypoglycemia. So if your patient is on metformin, DPP4 inhibitor, if the patient is on SGLT2 inhibitors, you don't have to worry much because this drug itself, they do not cause hypoglycemia. But sometimes prolonged fasting can cause. But if the patient is on sulfonylureas or the insulin, definitely you have to adjust the doses. So these are the recommendation. If the patient is on metformin, the patient taking metformin alone can undertake fast safely. So as I said, this is not a drug to cause hypoglycemia. 2/3 of the total daily dose should be given immediately before the sunset. That is before iftar, and 1/3 before the pre-dawn meal. Slow release formulation, that is sustained release or extended release formulation of metformin are well tolerated and can be taken once daily after sunset meal. So these are recommendations for metformin. Remember this. This is an important part, sulfonylureas. For patient adequately controlled before Ramadans, if the HbA1c is well controlled, and if the patient is on once daily sulfonylurea, you should change the timing from the usual morning dose to before the sunset meal because they eat more in the sunset. So if the patient on once daily sulfonylurea, you should give that sulfonylurea in the evening hours before iftar food. And if the patient is on twice daily sulfonylurea, then you should give half the usual evening dose before in the morning while the usual morning dose in the sunset. So higher doses in the evening hours. This is just opposite to what we practice in daily routines. We give more doses in the morning hours, lesser doses in the evening hours. But during Ramadan, because they eat more in the evening hours, you give more doses in the evening and the lesser doses in the morning. So twice daily sulfonylurea, half the usual evening dose in the morning while the usual morning dose in the sunset meal. There is no need to adjust the doses of the DP4 inhibitor or the gliptins. Gliptins are not independently associated with the hypoglycemia as they cause stimulation of the insulin secretion and glucagon release in glucose-dependent manner, may be particularly efficacious when hypoglycemia risk is a serious concern. And in addition, due to their complementary mechanism of action, they are effective as an add-on to the metformin, thiazolidine, or sulfonylurea. So, if the patient is alone on the gliptins, no need to adjust the doses. Similarly, for the thiazolidine and the alpha-glucosidase, same recommendation, no need to adjust the doses. The 5-glutathione has been found to be safe and efficacious in lowering glucose during Ramadan in combination with the other oral hypoglycemic agent. The risk of hypoglycemia is very low and it is acceptable to continue with the prescribed doses of these drugs taken only with the meal during fasting. So no need to adjust the doses of the thioglutathione or the alpha-glucosidase inhibitor. Again, the important part, insulin. As I said, these medicine can cause hypoglycemia. So generally speaking, long-acting basal insulin is advised at iftar time. Iftar time means evening meal. So long-acting basal insulin is advised at the iftar time, and they are supplemented with the short-acting insulin. And again, here the analog will be preferred because they have shorter duration of action as compared to the hemolyinsulin. They act for 3-4 hours. So analog will be preferred over the hemolyinsulin. So supplemented by the short-acting insulin at the safar as well as short-acting insulin at the iftar, and again a basal insulin. Short-acting analogs before meal instead of the regular insulin is reported to be associated with less hypoglycemia and smaller postprandial glucose excretion in diabetic fasting in Ramadan. And person who are doing well with the twice daily mixed insulin are advised to take larger portion of the insulin dose at iftar and the smaller as sahur time. So these are recommendation for insulin in Ramadan. So longer acting insulin in the night and the shorter acting before sahur and iftar. There are many guidelines for use diabetic management during Ramadan. These are some guidelines, you can go through it. This is the International Diabetic Federation guidelines, Diabetes and Ramadan practical guidelines. There are South Asian guidelines for the management of endocrine disorders in Ramadan. And there are also, this is American Diabetic Association guidelines, recommendation for management of diabetic during Ramadan. This is update from 2010. This is from ADA. Again, they are in hand-to-hand with the IDF guidelines. So before Ramadan, if the patient is on diet and exercise control, they consider modifying the time and intensity of the physical exercise, ensure adequate fluid intake. If the patient is on oral hypoglycemic agent, ensure adequate fluid intake. If the patient is 100 mg 3 times daily, then you should convert them metformin 1000 mg at the sunset and 500 mg at the pre-dawn meal. If the patient is on thiazolidine, alpha-glucosidase inhibitor, incretin-based therapy, no change is needed. If the patient is on sulfonylurea once daily, dose should be given before the sunset meal and adjust the doses based on the glycemic control and the risk of hypoglycemia. If they are on twice daily sulfonylurea, then half usual morning dose at the pre-dawn meal and the usual dose at the sunset meal. And if the patient is on insulin, ensure adequate fluid intake again. So similar recommendation as to the international diabetic guidelines. This is again same from the IDF guidelines. Yeah. So again, the second topic is finished, that is Ramadan. And just one slide for the diabetes and the COVID-19. Optimizing glycemic control is key to reducing the risk of serious disease as well as successfully treating people with hospitalized with the COVID-19. And you can take picture of this. This is the last slide from my talk. If the patient is seriously ill, hospitalized, then it is always better if the patient is, uninfected but living in an environment with prevalent COVID-19, you can continue all, whatever she or he is taking, you can continue with the insulin, metformin, DP4 or thiazolidons. If the patient is ambulatory having mild disease, again, you can continue all. There is no contraindication for anything. If the patient is hospitalized and moderate disease, again, the insulin are the preferred choice. Other you can use if required, if the patient is not getting control. And there is not recommended is the thiazolidone and the SGLT2 inhibitors, because there is increased risk of ketoacidosis or metabolic acidosis. And if the patient having hospitalized and severe disease admitted in the ICU, again the insulin and DP4 inhibitors are preferred. The DP4 are particularly considered as the safe because it was found in the studies that they inhibit the DP4 enzyme which is required for the entry of the virus into the cell. And it was found that use of DP4 inhibitor to certain extent help to prevent the progression of the disease. So in severely ill patient, insulin and the DP4 inhibitor can be used. Thank you for patience listening. If you have any question, I'll be happy to answer.